Good afternoon, everyone, and thank you all for coming. I really appreciate it. It's a beautiful day, and I know that I value your time here, and I hope that we have the opportunity to have some good discussion. And one of the things I like to do when I teach or when I talk is to really move around, which I'm not allowed to do that. So I'm going to be really struggling on that one. But the next thing I like to do is to involve those that I'm talking to, okay? So I'm going to ask you a couple times, not too many, just to kind of share some ideas and your thoughts, because I think that anytime we have discussions of these natures, they go better when we all are involved and engaged in them. So we'll go ahead and get right to it. Part of what I wanted to do first off was just kind of do, I'm a history lover. I'm a lover of medicine, but lover of history as well. So I always like to kind of look back as to what got us where we are today. There's a lot to be learned from that and so forth. So we're going to talk a little bit about just healthcare in general and healthcare and how it relates to the Catholic faith. And then we'll move from that just to looking at some of the commonalities that you may or may not be aware of between some of the moral issues of the Catholic faith and healthcare in general. Not only Catholic healthcare, but healthcare that goes on outside of the Catholic health system. And then we're going to look at, this is where I need your help, to kind of talk about some of the things that you think might be some of our bridges in healthcare. And I would be remiss if I didn't also talk about some of the barriers in healthcare, okay? And then we'll conclude with also coming up with some tools that we can use together and at an individual level, also at a global level, of how we can build bridges to improve our healthcare. Okay, so that's kind of just a little bit of what we're going to do. And feel free to get up and get a snack or two while we're doing this. And if I can't move, doesn't mean you can't. So please do that. So we'll go ahead and get started. So I wanted to talk a little bit about the church itself and the common goal of caring for the sick and the poor, and how that really transferred to establishing healthcare orders within the church, sisters as well as priests and other orders from early on, goes back before Middle Ages as far as how the church really was involved with care of the sick and the poor. And so that's really a foundation of commonality that we want to talk about. So in the 1700s, the Sister of Ursuline came to America, and they really started, which is interesting, the second hospital in the United States was started by these sisters, and that was in New Orleans. And that was the charity hospital, which initially was called St. John Hospital for the Poor. An interesting and somewhat sad fact about that hospital was the second hospital to be started in the U.S., Catholic-based hospital. That hospital was active for hundreds of years until Katrina hit in 2005. And the hospital still stands vacant now in New Orleans, but it was not reopened after Katrina. But a very powerful start to healthcare in the United States. So the Catholic Health Association is a group that is comprised of the health systems throughout the U.S. with a base of Catholicism. They look at, when you look at healthcare, you can't talk about healthcare without looking way up here at the big systems, but we also want to look at the middle and at the individual level as well. So the Catholic Health Association is a group started in the early 1900s with physicians, laypersons, as well as clergy, and to really try to come together with commonalities of the Catholic faith and how that relates to healthcare. So, but this group has continued to grow, and it's really a large presence in healthcare across our entire country. 600 hospitals, 1,400 long-term care facilities currently in the United States are governed under the Catholic health system. Every day, 1 in 6 patients in the U.S. is cared for at a Catholic hospital. So without even looking at healthcare overall, we already know with it being Catholic health systems, there's going to be association with the common good and other things of that nature. Catholic hospitals, clinics, long-term care facilities, they all embrace the caring for people of all ages from conception to natural death. These are motivated by the healing mission that was brought by Jesus and the foundation of the church. The mission reveals the vision of healing that goes beyond medical care to meet the holistic needs of people, families, communities representing the dignity of each person. I've worked in healthcare for 20 years, and I've had the privilege of working at 2 large Catholic health institutions. When I was at the Media Health Associates in Westerville for 17 years, I worked at St. Anne's, which is part of Mount Carmel Health. I worked in the emergency department there for 17 years. And I can tell you, being involved in a Catholic health system, being involved in really it is the primary door for many for primary care in the emergency room, and seeing the charity, seeing the basis that the church has with healthcare, it was truly profound on a regular basis. The service, the outreach, and things that were given to patients. So showing that it's present in various systems is very important. So the Catholic Health Association has a commitment. These are commitments based on the Catholic Church to promote and defend human dignity, attend the whole person. This we'll talk about more, which is very important. Care for the poor and vulnerable persons, promote the common good, act on behalf of justice, steward resources, and act in communion with the church. So as we've talked about with the common good, the church has taught in many places, this refers to human flourishing. This is a key premise in healthcare. We want you to flourish from birth to death. And that's what, in various aspects of healthcare, we're committed to trying to do for you. The Second Vatican Council, as we've already talked about, explained the common good as the sum total of those conditions needed for the well-being of individual persons and the groups of which they are part. So I think that, first of all, I wanted to draw the relationship with the common good and Catholic health systems, which I think is somewhat evident. The common good is an impetus for action, okay? It's not just a principle. It's an action. It's something that we need to do. Rather, we're talking about healthcare today. I think this series is wonderful as it talks about various aspects of our community and our lives. So when you see this little icon down here in the bottom, that's the key that I want you to talk to me. So I do that usually in class so that so I don't forget to ask, for one thing, because I can get talking and forget, but also so you know. So just in general, before we get into being more specific, what are some thoughts that you all have as this group? I mean, this is a wonderful group with lots of different backgrounds. So what are some ways, actions, processes that you think that may reflect the concern for the whole person and communities and outcomes associated with the common good in relation to healthcare? So what do you think? What are some things that you think are in place now that relate to the common good and how they relate to healthcare? What are some thoughts? Just shove a few out there. Public health, absolutely. Mm-hmm. Right. The public health, really the doctrine of public health and the premise of the purpose of that, yes. Mm-hmm. Ensuring that there's certain minimal things that all people should have. Doesn't happen. That's a different discussion, but that's very true. Anything else?
In some hospitals, they have personalized care where all the disciplines come together to make sure that they're doing the right thing for each single individual person. It's really growing.
Yes, like a team collaborative, patient-focused. Those are things that, and bringing individuals from different practice areas and disciplines to focus on the patient and outcomes for that patient, because you need A to B to get to C, and if you try to get from A to C without B, it's a struggle. Okay? Yeah.
Having pastoral care and social services too.
Yes, and I can say that having been at Mount Carmel, that was a huge, presence for us, and I think that people took it, I think providers often took it for granted that was something that we could engage, because they were there, and it was an important part of healthcare. No matter what the patient's religious beliefs were, having that spirituality piece there is very important. Okay. So just some thoughts to put out there as far as, we're not going to go over all these obviously, but these are just some thoughts, some impetus for action that we can discuss and think about going forward. Access to care, okay? We will talk about that. Do you think that's a barrier or a bridge? Should be a bridge. It's probably both, right? Free clinics, patient-centered medical homes. We'll talk about that a little more in a bit. Disease prevention, health disparities, public health, ethical misconduct. Okay, this is one I think that you may not think of so much, but in the history of medicine, there's so many times where what was thought to be ethically sound for the promotion of advancement of medicine is not always ethically sound from a human perspective. Okay, the Tuskegee experiments with syphilis in the early 1900s is one of the prime examples of, did that advance medicine? Yes. Did that affect the individual human, and was it a terrible example of not looking at an individual and withholding care to see what would happen? Yes. So, those are things to think about. Medicaid, Medicare, underinsured, uninsured, okay? Community in the sense of how is healthcare, a community without access to healthcare, a community without access to, clinics, hospitals. I mean, that's significant. Provider, patient, a shared purpose, okay? These are things that we'll kind of go with. So moving to thinking of, we talked about, overall, some general, just a very general discussion about the common good, some discussion about the history of Catholic health care and how that is grounded in the common good. Let's kind of think about health care, okay, just aside of that. And look at the parallels to what the Catholic health system does as a basis of the church. But this isn't really based on the church. This is based on the ethical approach to care for the human, okay? So 4 basic principles for the basis of moral thought in healthcare that are well recognized. Autonomy. What do you think that some examples of that might be in healthcare? Kind of gave you a little clue here, but. What's that? Right, arranging that care the best needs of you, and where that maybe takes place for you. There's some other thoughts, yeah.
The respect that an individual can refuse the right to treatment if they so choose, if their sin is conquered.
Yes.
So just because somebody's suicidal, you can't force them to take
Right. That's very good. What about non-maleficence? What about that? The concept of that. I think that goes with often we utilize that premise a lot in making a decision for patients. We don't want to harm them. We don't want this treatment. Or does the treatment outweigh, the consequence? Is my how I'm going to be living during this treatment? Is it worth what I'm going to go through? And giving the patient the choice of that. So piggybacking back on that autonomy, can they choose it? And why are they choosing it? And what's your involvement in that from the healthcare perspective? Benevolence. So acting to remove harm, preventing and promoting benefit and justice. So equality, inequality. We'll talk about a little more about that in detail in a few minutes. But unfortunately, the nature of our system, there's inequality. The amount of deductible that you have, the amount of coverage that you have. It goes from health care, dental care, all those things. There is definitely inequities there. But let's look at ways we can kind of come together with that. So autonomy, just to kind of give you a little bit more about that, protecting privacy, HIPAA, which can be so painful at times, but is also so valuable. When that came into effect, working in healthcare is difficult. Someone wants to know information about their loved one, and if you don't have the consent to do that, you can't do that. Unless it's something that, you can show that person is not able to represent themselves. Treating each encounter with respect. One of the things I tell our students from the beginning, I tell them multiple times, is every patient deserves your best every time that you see them, and that is really hard to do. But that's what you have to work towards. And if for whatever reason you're not in that space, you need to either give yourself a couple-minute break or you need to do something, because that person that is there relying on you, they shouldn't have to suffer the consequence of whatever's going on with you. And that's difficult sometimes. And all of our, and whatever job that we're doing, but especially when you're working with someone that is ill. And so avoiding the causation of harm, interfere whenever a patient's safety is at risk, promote a safe environment, monitor their environment for safety hazards. So these are all things that healthcare in general, moral purposes that we have to have in our mindset when we are treating patients, when we are setting up clinics, when we're setting up health systems, when we're referring you to someone. These are all premises that we should have in our minds when we're doing that. Act to remove harm or promote benefit, treat individuals equally. So not going into that. We want to ensure that the care that we give is individualized. We want to make it to where it's making that person the best that they can be. So kind of the point of that discussion was for you to see some parallels with the Catholic teachings foundation with healthcare in general and how many of these things are already very similar. So the AMA's Code of Ethics makes clear the obligation to show compassion and respect for human dignity. Familiar wording, okay? Compassion and respect and rights in regard to the responsibility of the patient as paramount. So that is really what we're supposed to do in healthcare. Whether I'm a provider, whether I'm someone that's a CEO of a health system, those are things that I should have in my mind. Whether I'm setting up a clinic, whether I'm providing a mobile unit to go to an underserved area to provide care. Those are things I should keep in my mind. Okay. The common good in healthcare. So we kind of gave you a nice little intro, I think. We're going to talk about some bridges that unite us. Then we're going to talk about the barriers that might divide or limit us. Okay? So there's your cue. What are some things that may unite us with healthcare? What's some things that might be present that are uniting factors? Any thoughts? Yeah.
Well, I think there's been a change in how we educate doctors, PAs, nurses.
It's okay.
Where it's they're becoming much more communicative. Where before there was this a bedside manner has become a common word. And even in that, as Barbara mentioned earlier, around the spiritual aspects, doctors, nurses, PAs have more information, at least information about that, are much more willing to call in someone.
Absolutely. That's and that's one of my favorite points. Absolutely right. The ability, empathy, compassion, those things that are part of our healthcare system that are aligned perfectly with the common good and how that's teaching. Yeah.
I think that the communication between patient and physician has really changed with the ability to log into a portal to see results or to communicate. You're almost as if you're partnering with
That's right.
a physician rather than there's this distance and there's the old folder, which you never got to look at.
That's right. No, that's right. And that's definitely, technology can be looked up at as it could be a barrier, but it's definitely a very big bridge, and that it does make you more of a partner in some of the occurrences that you are having. And it gives you access. Access is a word, we could say access to a provider, but access to my own information. And so I can actually be informed. And so where I'm going, I know what I'm talking about, and so I can take more active role in what I'm doing. And so that all goes back to that, I think, that human component of what we have to keep, in our minds with healthcare. So these are some things that I wanted to kind of focus on that I think are main premises or bridges of healthcare that are uniting facts and processes. Human dignity or connection, empathy. And so I think that is one of the leading things that in really the last decade has made tremendous improvement. Best practice. What is that? Best practice. Best practice. How's the best way to do this? And the way that's being determined is not just because it's what they've done for 50 years or 20 years. It's based on, like it or not, metrics. But the metrics that are looking at how does that impact you, okay? metrics that measure the individual, not, just times and things like that in health systems. These are shifts and trends that are being utilized and are being taught and are being focused on. Patient valued centered. That means that, when we're looking at things, we're looking at what is best for you. If you are given a diagnosis, how does that impact you with everything that's going on in your life? You're a mother, you're a father, you're a sister, you're a husband, you're a wife. How does it affect you as an individual? Spirituality, it's a huge bridge, and that is, I think, prevalent not in just the Catholic health systems, okay? But I think that with the Catholic health system being such a predominant key player in healthcare, it's a great opportunity for that to be shown as why that's so important. And service, okay? So this is the trick of having a video in your presentation, as you all know. I hope it works. We practiced ahead, so we'll do that. I have a short video I want you to see. Many of you may have seen it already. It's one of those, it's like 4 minutes. It was produced by the Cleveland Clinic. It's on empathy. If you've seen it already, I've seen it probably 30 times, and every time it's striking to me. So I hope that you enjoy this. So I'll get it going here, we hope. We're gonna hope and try that it works out. Actually, that was good. think about that? Yeah, what are some thoughts about that? Yeah,
It's bigger than healthcare.
yeah, that's right. It's bigger than health. What's that?
You don't know what your students are going through, what they're experiencing, if they don't tell you.
Right.
So I agree with you.
Right, and I think it just goes to say even that premise, and we talk about it, with healthcare, but that empathy and the human connection is vital in all that we do. And when you're able to do that as a provider, when you're able as a health system to implement processes that encourage the providers, encourage everyone that is participating to look at things like that and approach things like that, the patient response is dramatically different. It's not always easy to do that, but yeah.
I have to tell you, that's not my understanding or my thinking how healthcare providers are educated, that they should be insiders on people's health. They are, it's kind of like you should always have that step back so you could be, quote, objective. And
Right.
so it's refreshing to see an institution like Cleveland Clinic
Yes.
to put out something like that, because there is this feeling that you should be hands-off so you can make the right decision rather than connect.
Right.
I've been doing some research about this.
Mhm.
It's a new part of
Yes.
training of all fields of medicine that take the spiritual inventory, trying to be aware of the whole setting of the person. It needs to be part of the consciousness of every person who is in contact with the patient.
Right.
And it is a flippant model, even from when I did CPE 30 years ago. But I was wonderfully surprised to see that.
Right, and some of the leading largest systems are really encouraging this and really putting it at all levels of care and implementing it into education of the providers at all levels as well. One thing I tell our students is that healthcare is one of those situations where if you work in a hospital or you work in an office or you work in a clinic, you work around people of all different backgrounds, all different education levels are all needed to come together. And I think that's the other thing this video also points out of the way we have to unite in order to meet the patient's needs. And I think that taking that ego out of the provider and putting it, really focused to the patient, the individual, the patient, and how we as groups work around that person and work with them, not that it's working around me and what I want as the provider or as the health system. It's not easily done, but this is definitely a shift in thought process, and actually it's a shift in best practice, which is wonderful. Best practice is what they all want us to talk about, and they're studying that implementing these as part of how you work with patients and how you approach the first step into the health system of the patient makes a difference, and it's altering to all involved, really. So with best practice and empathy, the patient is not the same as the illness, and this is something we really have to focus on, because in all honesty, when you're looking at a patient, you don't want to miss the illness, okay? Because you don't want to miss that. So you have to think about that. You have to be getting, things from them. But the whole person is what you're looking at. So not the MI, which, myocardial infarction, not the MI in room 5. That's not how we want to look at people. It's not how we want to look at patients. It's not how we want to do what we're doing. We want to look at them as the overall picture. So really in the last 5 to 7 years is really where this has gotten a lot of momentum as far as research and studies showing that doing this is not just nice and we don't just like it better, it actually shows that people do better. Okay, so in the last 5 years, showing empathy and focusing on the emotional intelligence of providers, of health systems, of communities, because it's not just the provider, it's not just the health system, it's the community, it's the parishes, it's the schools, it's, you know, looking at providing for a group of people. And healthcare is something we all have to use at one point, whether it's through our own use or our family's use. And we all have, you know, we are all engaged in that process. So focusing on the emotional intelligence of these systems are shown to bridge gaps in care and promote the human connection. Implementing empathetic care and processes have been correlated with improving effectiveness of healthcare, decreasing time of visits, increasing healing, showing better outcomes. Metrics are being analyzed to determine change when empathy is embraced. And that's the exciting part from my perspective of, you know, really, yeah, I've thought this was a good way to do things, but it is a great way to do things on many levels. Targeting key interventions at various levels in healthcare to make an impact and align with the common good is really what I think this big bridge of best practice and empathy is. A huge, wonderful opportunity with all the inequities that are out there. It's an opportunity. Patient value focused care. Providers and health systems shifting to the patient. Team-based, patient-based. Have you all heard of patient-centered medical homes? Is that a term that any of you are familiar with? Or patient-centered medical homes. So there are many of them in Central Ohio. I've been involved in a healthcare group now for about 4 years that meets quarterly, and it's really a movement. All the health systems in Columbus are involved. And really showing that kind of like what someone over here said earlier about how when I go to see my provider, I'm going to one place and I'm going to have access to the pharmacist, the dietitian, the therapist, the physician, the PA, the nurse practitioner, or whatever that model is at that practice. And studies have shown that care is improved. And there's metrics of things that they look at from the provider standpoint, but it's a movement that's happening across the country, and Columbus is really doing a great job at trying to, the health systems put their guards down and work together, because it won't work otherwise. And so they're interesting meetings, they're fascinating, but it's something that is definitely trying to unite and provide better access, not just that initial touch of healthcare. That's the problem. You might go to see some person for a problem, but then that kicks into other things that you need done, and if there's not a connectivity there, it becomes difficult. Shift discussions and interactions to the positive, respect for the person in the community, transparency of services. And you mentioned that, Bruce, as far as, would it make a difference to you if you could find out the real cost of some of the things that you're being charged? Would it make a difference to you to know that the provider that you're seeing, to look at their outcomes, their infection rate, their readmission rates? Would that make a difference to you? Because that informs you to make your own choices. And that is definitely what's happening in healthcare now. And that's part of this Access Healthcare Columbus. They're also, you can log into websites and you can find out everything you want. And some health systems across the country have implemented that. And it's actually shown to improve patient outcomes and improve the interaction of healthcare. But it's something that I think to think about. Spirituality. The mission of Catholic Health promotes the collaboration among healthcare leaders, providers, medical professionals, theologians, and that's the mission of that, promotes that. The ethical and religious directives of the Catholic healthcare services indicates the dialogue between medical science and Christian faith for its primary purpose, the common good of all health persons. It presupposes that science and faith do not contradict each other. Both are grounded in respect for truth and freedom. A new knowledge and new technologies expand, each person must form and correct conscience based on the moral norms for proper health care. So in the climate of shifting partnerships in healthcare, we all know that, right? Our healthcare carrier can change, from one year to the next, or whoever you go to may not accept the healthcare that you had previous. So there's active change and flux in healthcare. But in the climate of shifting partnerships, relation to billing, reimbursement, financial sustainability, the Catholic health system has the opportunity to help bridge spirituality in that process to align the common good with these partnerships. So I think that's very exciting. and what we could see happening. The Catholic healthcare can be marked by the spirit of mutual respect among the caregivers. So this is definitely a bridge of uniting us to assure that the right of each person to basic health care is respected and promoting the good health of the community. You want advocacy for your patients. Social conditions puts them in the margins for society and makes vulnerable to discrimination. So the poor, the uninsured, the underinsured, children, unborn, single parents, elderly, those with incurable diseases, chemical dependencies, racial minorities, immigrants, and refugees. So the spirituality bridge addresses these issues and actually is a wonderful foundation of how we can address the individual and also utilize these processes in the place of doing that. Service. This was the last main bridge that I wanted to discuss, is reaching out at the individual, provider, practice, community, state, national, international level. We know this is successful. We know this is impactful. How many of you have done that yourself? Whether it be a medical mission trip, whether it be working at in some type of clinic somewhere, whether it be providing meals, anything for in a service type environment. We know that this makes a difference, okay? And we know this is a great opportunity to continue to further that. Building bridges for access, for provisions, medicines, treatments, for the daily need in the event of, in the daily need of patients, or obviously when catastrophic things occur as well. So this is involved at the ground level of all teaching, service to bridge healthcare, education, spirituality, business, and technology. So it's an opportunity to use service with healthcare, the common good, to go across lines and to really activate action and change. So the guiding force for agents of change and tools needed for building bridges and creating unity. I think this is what we do here for our students, and what's common being done as well is getting them engaged early on, showing them the benefit of that, and how that can make a difference for them going forward. So we talked about some bridges. Okay, yes?
This connects with the service aspect.
Yes.
I think there's a tendency now to have physician groups, sometimes with as many as 36 physicians in a group. And it connects with the empathy, because my own personal experience, I've had some marvelous experiences of empathy from nurses that get to know you because they're there a couple of days a week and so on. And then you have a doctor you see once, and then you see another one in the afternoon, and then you see another one the next day. You never see them again.
Right.
And the empathy is an entirely different level there.
Right. And I think that unfortunately, I think what will have to happen, which we're seeing happening, is in order for some of those changes to occur in certain provider situations, is they have to be shown that it's not just the right thing or a good thing to do, but it actually, through metrics and outcomes, it improves the care of the patient and taking it out of their own realm. And unfortunately, sometimes it's not an easy process to make that bridge happen in that situation. But I think the awareness that overarching theories of this is what we need to do better, and this is what we're showing works if we're doing this more, I think that it will make those things change. One of the things I was reading was talking about how education and the process of onboarding of providers, nurses, physicians, all levels of care, are embracing this process of empathy and communication and partnering with the patient. Those are all things that are very important. But getting the inclusion of health systems, larger groups, is much more difficult. So the way of doing that is showing these outcomes via the metrics that look at that, yes, being focused on the person and showing those levels of involvement has definitely shown outcomes are better. That's one way of making those changes and coming through. But yeah, thank you, that's a good point. So what are some barriers that may divide or limit? So that's your little cue there. What do you think are some things? Yeah, Jim.
I love what you said earlier about every one of your students consider
Patients.
Patients needs to have the best that that person can provide. But I know that there are other structures, like bureaucratic structures, where PAs, doctors, NPs have to see X amount of patients within an hour, empathy may wane, or the fact that long working hours and conditions. So I would say one of the barriers could be the bureaucratic structure, or just
Yes.
the supply of competent healthcare professionals to be able to provide.
That's absolutely true. And that's why there's a high level of burnout, and studies that have been looking at burnout in particular and not providing the best, communication with patients. And by having providers go through empathy workshops and workshops on communication have shown drastic improvement in those levels. And so actually there's certain, levels of making this required that people have to go through this kind of training on a regular basis. And one study was saying that they need, people need to be recharged. Everybody does. We all need to have those come back to yourself and kind of look at things at a certain perspective. But no, absolutely, that's definitely a potential barrier of reaching out to others. Just some other thoughts. Anyone else have thoughts? Yeah.
There's misinformation is a big conversation in a lot of ways now, but I think really in healthcare, as somebody who has two small children, one thing that comes into our dialogue far too often surrounds the impacts having to do with vaccines and how that is beginning to really impact our communities and really the country and the world in general.
Right. So, and that falls somewhat under the public health that we talked about a little bit earlier. But yes, that's true. And how do you show? So how do you show that some of the thought behind that it is dangerous versus all of the research that shows that it's valuable? And so how do you do that? And that's definitely misinformation, education, ensuring that that the ethical conduct that we're going about and why we're treating, is there a reason to do the treatments that we're doing, and how does that fall in line with the individual at that individual level? Cost is definitely a barrier. Yes, absolutely. Yeah.
Location can be a barrier too. If you're not in a location that as a provider can provide, you don't have transportation.
Right. That's very true.
Regular access to preventive care.
Right. That's absolutely true. Yeah.
The arbitrary cost of drugs can be set by the drug companies with no one setting any boundaries on them.
Yes. Those are all definitely very profound barriers that we are facing. Absolutely. Yeah.
I think, you were saying before that technology can be a bridge, but I know, what's that pain? Let me Google it. And self-diagnosis based off the
Yes.
internet and treatment off the internet. I'm sure
Right.
is also a barrier to
Yes.
getting good health care.
Right. Right.
Program that in 60 Minutes talked about it, and the computer basically does the diagnosis. What is that?
Yeah. Not sure. Right. I know what you're referring to. Yes. And we reference that in the ER often when people come in. They have their, MedMD type thing already determined, which can be a barrier or can be a benefit. Their expectation of what it is that you're going to do for them versus what you need to do for them can be something that you have to negotiate as well and explore. So those are all great with those. So as you can tell, there's many. So I really kind of focused in on three main things that I thought we would discuss. Access to care, the affordability of care, the quality of care, and then treating the whole person. Okay. So access to care. We've determined in our discussions of talking about the common good and other things, even before my talk today, determined that healthcare is a right. I feel that is a right we all have. Okay, but there's not a universal access to care. Okay, so then you think of, and our health systems are comprised of not-for-profits, for-profits, free clinics, different types of areas where you can go for care. Not-for-profit facilities, they won't turn you away, right? So then, yeah.
There is dumping.
Right?
Government does go along
Absolutely it does, right.
Half the hospitals now want that.
Yes, right. And often transporting a patient to a facility is determined with that in mind. You're absolutely right. So you can't be turned away, but the other aspect of access is, what if you can't get there? So the access is that, you don't even have the ability to get the care. And rather that's actual, because you can't get there physically, there's not transportation, there's not a place for you to go, or the awareness that you need to seek the care is not there, depending on what that is. So it's something to think about, and I think that the access to care is probably, could be a very big lecture and workshop and generate lots of discussion in and of itself, actually. But what we have to look at is how can we work with what we have, and how can we lobby together to improve what we already I think we all agree that it's not ideal and it's not equitable. So how do we go about making it better? The Affordable Care Act and the need for reform of that act. And without going into, any politically based discussion, the fact that something was tried, had some things that were maybe positive, others that weren't, and we're still trying to figure out a better system. And I think the acknowledgement that we need a better system, because we need that equality of access. So is it universal or national health care? Anyone have any thoughts on that?
Certainly isn't this way in Europe.
Right, it's not? Mm-mm. No, it's not. So any thought? She's saying it's not this way in Europe, and there's a big difference with insurance companies. And really with healthcare in general, as far as in the U.S., big changes occurred when, there was a crash with insurance companies, not the funding for healthcare as it had been. And so then it became more, profit-based. And then this kind of just went from there. So we're in a situation where, how do you maintain facilities? You have to be able to do that. But how do you provide care for those that don't have the means to pay for it? There's many references to this in regards to the working poor. People that are working poor, in that you have insurance, you pay for what you have, but yet has limits, higher deductibles and all these things, and it's really a huge problem that we all are involved in on many different levels. So I think that I was trying to kind of go with how I could incorporate that without it becoming the full purpose here, because there's not a lot of current bridges there, but there's ways for us to discuss opportunities, and I think that's what you have to look at. What are some opportunities with the system that we currently have, and what are some ways that we can improve where we are? And also acknowledging that there needs to be some type of changes occurring. We just don't necessarily have an agreement of what that may need to be at this time. So another big barrier with access, and it somewhat goes hand in hand at times, is affordability of care or quality of care. In the U.S., access to medical care is obstructed by the high cost of care. So I may have insurance or the ability to go somewhere, but knowing that I have a $500 deductible if it's an ER visit, but I don't have a primary care person, so what am I supposed to do? Over 2 million Americans will declare bankruptcy due to medical costs annually. Healthcare expense is the most frequent cause of personal financial collapse in the U.S. right now. It's terrible that is the reality of where we are. America's poor of any race or ethnicity are sicker than the well-off Americans in general. There's an unequal economic opportunities, unequal education, and often associated with despair. So these are barriers in, from an economic standpoint, from a resource allocation standpoint, from a awareness of what should I do for myself standpoint, and support. And unfortunately, it snowballs often. If you have one barrier, then you often have multiple. So these are things, I think, awareness of this. I think looking at ways we can utilize some of the bridges that we acknowledge and trying to see how we can shift and come up with potential options. Care-based from profit-based. I think this is what you'll see. You'll see a lot more of this, more of a care-based type process than a profit-based. It's not necessarily favorable for all types of specialties in medicine, but overall, I think this is there's going to be a shift in what we'll see here. That's something that I think is definitely needed. Inequality. Dr. Catherine Baker, she's a professor of health economics at Harvard Chan School. These are 2 quotes from her I thought were kind of summed up some of the things that we're talking about here as far as barriers. Insurance is not just supposed to get you access to care. It's supposed to keep you from getting evicted from your apartment because you paid your hospital bill instead of your rent. Okay, that's reality in our world. And our coworkers, our friends, our neighbors, okay? She thinks an important factor that is sometimes overlooked is there are a lot of observed disparities in care based on income, race, ethnicity that are attributable to the quality of care in some parts of the country lagging behind other parts of the country. So it's as much as about where you live as what your characteristics are. So if you happen to live where we do, in Columbus, Ohio, we have a lot of opportunities for care. We don't necessarily have better options for the cost of those opportunities of care, but we've got care that we can access. And care that is probably follows best practice most of the time, but in parts of the country are not that way. And so not only are we battling the issues we talked about with cost and resources, we're battling across nationally about what's even available, and that definitely further determines those barriers as we talked about a few minutes ago. So another issue is treating the whole person. Care that we do offer, so we get our care, should not be limited to the treatment of the disease or bodily ailment, but should embrace the physical, psychological, social, and spiritual dimensions of the human person. And that very much coincides with the common good of how we're looking at things. However, that's often not the case. So as we talked about these changes in education and empathy and communication and looking at patient-centered versus provider-focused, okay, those are opportunities and bridges of things that I think will enhance what we have. But we have to still acknowledge that, unfortunately, there's still a lot of these other things happening. Often the social context or conditions of healthcare need to be addressed. The community needs to be supportive, needs to be engaged, needs to be recognized. Treating the whole person and treating all persons. This is something I just thought of how meaningful it can be when you as a person are seen and heard, no matter if it's about healthcare, if it's about anything, and how disappointing and isolating it can be when you're not. Okay, and this is where we are in many aspects of our own country right now, and I do believe it can improve. I think hope is a foundation of that. So, what are some tools that we can use to build bridges that connect these disparities? The things that we talked about, the barriers we mentioned, all the things that you all brought up as barriers they're all there. What are some things that we might use or we might be able to do? Some thoughts that you guys have. Yeah.
Imagining the patients you're seeing is your father.
Right?
Or your 7-year-old self.
Yes.
Try to remember.
Right. Seeing that patient for the individual that they are, or putting yourself in, one of the common phrases that are always used in healthcare and medicine, would you want me to treat your child? Would you do the same for your wife, for your husband, for your child, for your family? And often patients ask us that. Is this what you would do if you were me? Okay. So yes, that's excellent. Yeah.
I think we can all continue advocating for change.
That's right.
Decrease a lot of these discrepancies and disparities.
Mm-hmm. Right. Advocating for change. Mm-hmm. I agree. Yeah.
Besides changing the healthcare system, the economic system. So, for example, there are better healthy choice eating options,
Mm-hmm.
or facilities in the neighborhoods where many of our poorer sisters and brothers live.
Right.
So that they can have the access that will help prevent further complications.
Right. Some of the things I wanted to focus on here were engagement and shared purpose. Just kind of being active and trying to do something about it. Technology, how can we use it differently? Activation training, which is an exciting thing I want to talk about, and continued outreach. So engagement and shared purpose. I think when you're talking about, you have 36 physicians and you see one and then you see another one and then you kind of are doing the dot plot of things and they never come back around to make a loop. You just kind of a linear type process. I think that one of the things that the studies and research are putting out there to educate providers are to come up with a shared purpose. Not that you're just here to treat medicine, but what is the purpose? What is the goal? What is the goal of your clinic? What is the goal of your health system? What is the goal with your patient? And these are all, studies have found that physicians have a much better level of engagement and better outcome and treating the individual better if they're looking at their shared purpose of why we're doing this together. So it's not me, it's not you, it's together. So I think it's very exciting. It looks at what is the best for the patient, how the provider and the patient can be engaged, things of self-interest, respect, tradition, setting goals. Those are things that often when you go to see a provider, you sit there and they come in and, I didn't put this on the slide, but it's very, very well documented that in the first 18 seconds you're with your provider and they're talking to you, they interrupt you. They're done. They interrupt you. So that in of itself is trying to shift that away from that process. 18 seconds, that's not very long, okay, at all. Technology. So with medical discoveries, technological developments, how can we make this a tool? How can we build bridges with this? I do think that there's a lot of focus. What we focus on a lot is to make sure technology doesn't separate you from the patient, that you're not looking here and not looking there. And I think that there's a lot of focus on that. So I think there's awareness of that. It still probably happens some. But what are some things that we can use technology for that maybe we aren't, or that we're not familiar with? Telemedicine is already annually doubles in outreach to patients. The problem with telemedicine, though, is that if you're in a very low poverty-stricken area, often the telemedicine isn't going to be there. So that's a problem. But I think that the health systems themselves are outreaching to more rural areas with telemedicine, and I think that it's a great opportunity for this. Have any of you ever used telemedicine? If you have something, that you have wrong with you, you can, go to different servers and subscribers and see, virtually see a provider and be asked questions and, go through that experience. So I think that you will be seeing that more and more. And there's actually standards and best practices that are being established solely for telemedicine purposes. Activation training. At your seats, there is a sheet of paper that I laid there for you. And if you could just take about 2 seconds and read that situation that I maybe put in front of you. And activation training is really focusing on empowering the patient, okay? And that when, as I said, that 18 seconds you've got, well, first of all, we want to make that go away, but how do you best utilize and communicate your needs, or what is going on that's a barrier for you that you're not going to get the most out of this engagement with your provider. So activation trainings make health and care more personalized, anticipatory. So, in education, we have to say clearly, this is what we're going to do, this is what you're going to expect, this is, how can we get you there? But when we go to our providers, we just show up, and we hope that we think of the questions that we should, and we hope that they cover the things that they should with us, which isn't really the basis of making sure the sum of the good for that person is being looked upon. So there's a patient revolution going on right now in various health systems where they're really trying to educate, and especially the more high-risk populations of our country, of how when you have the opportunity to be seen, these are the things that you can do. So one of the things one of the areas I have for you, and if you have this one I put up and you want to make a comment on yours, I would be grateful, but I understand. One of the things is I don't want my comment or question to make me appear unintelligent or concerned about the wrong things. How many of you have thought that when you've been in a practice? I have myself, you know? And I think especially sometimes when whatever we're doing, mine is healthcare, whatever yours is, whatever area that you may should know some things about, well, I don't want to ask a question that would make me be perceived inappropriate. But that's something we have to activate patients to get past, because it's your right to do that, and to best find out what you need. Anyone have thoughts on this one if you have this one at your seat? I think it's something that I think we all think of.
I'd be curious how gender plays into this one.
How what?
How gender plays.
Yes, I think that would be interesting as well. How gender differences could impact this.
I also wonder if generational differences.
Yes, absolutely. I don't want my doctor to think of me as a difficult patient. Okay, I don't want a star on my chart that says that I'm not, I'm a problem. But at the same time, you want to find out what you need to find out. So I worry I'll be judged if my choices are different from what most other people would do. So, well, this is what you have, and this is what we do. Well, maybe I don't want that. And you have the right to do that. And you should do that. I assume that the doctor's recommendation is the only option or the best option. Again, that goes back to what we were talking about, having access to your chart, your records, having the ability and being encouraged. So the thought behind this is that practices would be encouraging this from you when you're sitting there waiting. They'd be providing these things for you so that it engages you and activates you to feel that you should be asking these things, or not being made feel a certain way to not ask. I worry I'll be judged for considering cost in making decisions about my health. It's true. It's reality. And that is, you shouldn't be. You shouldn't be. I assume that if an aspect of my life is important, the doctor will ask me about it. No. You ask for ask and activate for yourself. So other areas or tools that we can utilize, I think ongoing outreach is, what we talked about, from the patient, payer, providers, health systems, public communities, parishes. We all play a role in engaging the community, identifying needs, conducting analytics, developing partnerships, implementing and evaluating evidence-based interactions, which will influence change. The common good, bridges that unite healthcare. In closing, empathy and compassion and human connection, I think, is recognized as vital in determining access. Equity, delivery, and outcomes in healthcare and are crucial in laying the foundation for identifying barriers and building bridges that unite us in healthcare. So my challenge is for all of us to be a bridge or help in building a bridge for human flourishing. So. Yes. It is, right. And then I think that's a shift of, instead of walking into a room or into a clinic and you sitting there and being told, this is what's wrong with you and this is what we're going to do, it needs to be a two-way dialogue. And I think that is something that we all can, be a part of. Some of these other things that we talked about as barriers, each of us have as much ability to impact that today, but we can impact things in other ways. And I think taking that ownership and creating that relationship, engagement, is a huge way to do that. So, yeah.
I'm wondering if, as the healthcare industry is working to better train providers on that empathy factor, are they also considering training pieces as well, knowing some of those barriers to communication or questions that the patients have? I have a personal experience with
things and mentions, and when it's just the two of them going to a doctor's appointment, we don't know if they are ever going to really hear the
Right.
message or not. And so, what awareness kind of training are the providers giving? People in this.
Right, and I think there are awareness training happening now. I think that really in the last decade, that's become more acknowledged that it matters, and I think that comes from us saying it matters. Got to say it matters, because it does. So, yeah.
I just have to say that in a university, I keep thinking of the university.
Sure, absolutely.
And we can model this
Mm-hmm.
by the way we treat one another. And,
Mm-hmm.
you know, because you're the director of some program doesn't make you any better than the person just.
Absolutely not. Mm-mm.
And how do you teach students
Mm-hmm.
to name what they need
Mm-hmm.
and not do all these same things to the students that we don't want to be happen to us when we go to the health facility?
Right, well, I definitely think there are transferable issues and transferable skill sets of how we can approach them. And I think that if we do that at the level of university level, community level, I mean, it just empowers the process. I do. I think I'm hopeful. I'm hopeful of changes that will occur. I really am. Yeah.
It's kind of training to
Right. Yes. Mm-hmm.
try to start off with that.
Absolutely. Absolutely. Yeah.
And I think too, one of the other big things for health providers is an emphasis on compassion for yourself.
Mm-hmm.
Right? So there's a big issue I've read about at least with doctors and people making mistakes.
Yes.
But not wanting to own up to that, wanting to
Right.
feel like they're perfect all the
Mm-hmm.
time.
Mm-hmm.
You know, but everybody makes mistakes.
Right.
So how do you have that compassion for yourself to say,
Mm-hmm.
oh, I made this mistake here, and how do
Right.
you learn from it? And like,
Mm-hmm.
I think also what it's like to faculty is everybody else, right? Because we're all
Right.
human, you know?
Yes.
There's not that distinction.
Yeah, when I think that when you are part of a process, whether it be your medical visit, your education visit, your educational exchange with, experience, if you are a part of it and something doesn't go well, you're much more inclined and apt to be a part of discovering why it didn't go well and exploring what about it was good and what about it wasn't and what was intentional, not intentional. And when I was talking earlier about the transparency piece of would you want to know what your provider's track record is and things like that, they're showing that by putting that out there, it is making providers more willing to make changes that they maybe should have made, but they didn't want to change what they were doing, but they're making the changes because it's evident that maybe their process isn't what it should be. And so I think that then having that engagement with the patient, they're finding malpractice is less because the patient is involved. They were aware of what could happen legitimately at actually the health system they're going to. And putting those things out, I think, are options and possibilities for us. While there isn't any immediate fix for a lot of these barriers we talked about, and while many of them are definitely very profound, I think that we pull back and look at what we can do and what we can engage with and how we can make really good, impactful changes. So.
I think all these people that are trying to work with healthcare reform should have an understanding of all of this.
Yes, yeah, it would be great, yeah.
That would make a lot of difference.
Mm-hmm. Yeah, Brother Tony.
So I like the idea of how spirituality can make it more holistic.
Yes.
Sometimes the religious people are the ones that are there every now and again. And so I feel like some of my prayers, even at Mass, it's like I think I just was so focused on the soul. I think I just missed the point on the opposite side, praying for a miracle,
Right.
and sort of disrespectful to the healthcare profession.
Mm-hmm.
So I just was curious if you ever hear prayers at church about these issues and you just sort of think, it just completely misses the point.
I don't think so. No.
Miracles and
Yeah, no, because I think that goes back to the component of faith and the huge component of spirituality and faith in healthcare, and how that does play a role in what happens. Because despite doing everything often the way that you should, things don't always work out the way that you anticipate. So I think that's where that often that faith piece is very valuable and important in that process. But I don't think you missed that. So anything else? Well, I appreciate your engagement in the process. It's important, and I appreciate your time. Thank you.